Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Hello, good morning once again to this CATHIP Health Hour session. It's Saturday, the 2nd of July, 2022, and believe it or not, half of the year is already gone, and we are in the second half of the year, amazingly. I know that everyone is really busy, but you always take time out of your busy schedules to join us. So we are honored to host you this morning. My name is Dr. Diana Asante, a GP based in Stafford. And it is my honor and pleasure to host this morning's CAHN Health Hour session. As always, week in, week out, we bring you exciting and stimulating topics to help educate our community, empower us, and help us know a bit more about our own health and how we can improve these. And so today we have another exciting discussion centered on miscarriages and early pregnancy complications. And we will be bringing this to you. Our guest is very experienced in her knowledge in her area, and she is a consultant obstetrician gynecologist who will be talking us through this session. I'll introduce her properly in a minute. Now, I just want to say that this program is being streamed to social media platforms, and we are also on YouTube. We will have in the initial bit where we have the session presented by our special guest today. And after that, there will be a Q&A session for people to ask their questions. Please do feel free to post your questions in the chat box so that these will be addressed when we get to the Q&A session. We try as much as possible to improve the services that we bring to you, the quality of what we present week in, week out. So we highly appreciate your feedback. And during the session, feedback forms will be sent out so that you can complete these. Let us know how well or not well we're doing so that we can do better next time. We appreciate your feedback on the kinds of programs you'd like to have. We appreciate your feedback on the quality of programs that we present. The email address is health@cahn.org.uk. So do feel free to email your concerns to that email. Right. So we have a topic today on miscarriages and early pregnancy complications. And it's going to be given to us by a very experienced obstetrician gynecologist who is based with the Surrey Trust, Royal Surrey Trust. She is also the president of the Christian Healthcare Network, Christian Healthcare Professionals Network organization. She's also a friend because I belong to that organization as well. A very humble lady, very, very busy lady, but she has taken time out of her busy schedule to come and be with us. So it is my honor and privilege to introduce to us Dr. Chimwemwe Kalumbi-Mkambula. For short, I call her Dr. Chim. and most people call her Dr. Chim. So Dr. Chim, we are so happy to have you this morning, and thank you for honoring our invitation. Over to you, please. If there's anything I've missed out in the introduction, please feel free to fill it in. Thank you.
Oh, thank you so much, Diana. It's really a privilege and an honor to come on your platform. I'm very grateful to the executives of CAHN and also for the organizers of this event. I think we share common aspirations. As the president of the Christian Healthcare Professionals Network, our aim is to equip our Black communities, our faith communities in matters of their health and how they can also be knowledgeable and look after their bodies. I always say that, our bodies, God has given us as, temple of the Holy Spirit, and we're only given one body in our lifetime. And if we don't take care of our body, we cannot perform our duties in the appropriate way. So today is a privilege really to talk about something that I'm very passionate about, and that is miscarriage. And the reason why this topic touches me quite a lot is because of a lot of our African cultural barriers. We don't talk about miscarriages. And many of our women in the Afro-Caribbean Black communities, they suffer in silence, either lack of knowledge or because of the cultural barriers that they can't talk about these things. And we know that miscarriages, have got significant psychological impact on women's or couples' well-being. So today, we just thought that maybe it's really important that we look at this topic in detail. The main aim is really to make our people understand what is miscarriage, how does it present, when can they seek help, and when they go to seek help, what is it that they should expect? How are miscarriages managed? Early pregnancy complication is a big topic. So for the time being, we just want to look at the bit of miscarriage. At later sessions, maybe later in the series, if there's another opportunity, we can talk about another early pregnancy complication, such as ectopic pregnancy or molar pregnancies, and even other complications that are associated with early pregnancy loss. So thank you so much for giving me this platform. So I'm just gonna go straight to the discussion. Thank you. So on the next slide, I just want to declare my conflict of interest. I'm affiliated to a number of organizations, as seen on the slide previously. So whatever I'm going to talk about today is from my personal experience as an obstetrician and gynecologist, also as a specialist in early pregnancy complication. I do not represent the views of the organizations that I belong to. So thank you so much. I think just if we go back on the slide on what we're going to focus about. Yeah, thank you so much. So today's talk is about sporadic miscarriages. We talk about clinical presentation. Many a time, women have got ultrasound scan, but they don't understand what is written on the report or what their scan findings suggest. We're going to talk about management options and also the level of care that is expected for women to receive undergoing a miscarriage. As I said earlier on, I've excluded from the talk ectopic pregnancies, molar pregnancies, or another aspect of miscarriage which is known as recurrent miscarriages or repetitive miscarriages. Thank you. So why talk about miscarriages? It will be shocking if you look at the figures that actually miscarriages are very common than we think. 1 in 5 pregnancies end in miscarriage. And when you look at global every day, 23 million women undergo a miscarriage process. When you digest it to the level that we can understand, you're looking at 44 pregnancy losses each minute. And these are not just numbers. Behind these numbers, there are women, there are couples that are suffering, that are grieving, that are in pain. So miscarriages has also got a lot of psychological impact. You know, it can be a lonely place. Many societies, like our societies, we don't talk about it. So the woman will suffer in pain. And it can cause depression, it can cause withdrawal symptoms, it can cause anxiety, and it can also be really, really disturbing for them and really an anxious moment if they fall pregnant again, you know, because it's a worry, what's going to happen to my next pregnancy? So the psychological impact of miscarriages on the mental well-being of our women cannot be underestimated. And we also know that there's an economic impact as well. 50,000 admissions in a year in the UK in A&E, through A&E or through another admitting processes are because of early pregnancy complications. And when you translate it into the cost, it's actually about £471 million a year. So that's the reason why we need to talk about this. We need to educate our women what they can expect and how we can support them through this difficult time. And this talk is both to our communities, but as well as to healthcare professionals that deal with miscarriage or that deal with women that undergo miscarriages. Thank you. So let's talk about risk factors. Many times people want to know, why me? Why now? Why has this happened? When you look at the risk factors of miscarriage, age is the commonest risk factor. We're talking about age above 40 has a higher risk of miscarriage, but also age under 20. So when we look at the woman's life, reproductive life, from the age of 35, your risk of miscarriage starts to increase. In the men, age above 40 and 41 can also increase your risk of miscarriage. Obesity is one of the other factor as well. So if you're morbid obese or if you're very overweight, sometimes that can contribute as well to the risk of miscarriage. Just like obesity, we know is the underlying cause to so many medical problems. And recent research actually shows that, you know, being of Black ethnicity as well is a risk factor to miscarriages. So instead of being at home and suffer in silence, it's better that our people go and seek help as much as they can quite early. So history of previous miscarriages as well, smoking, alcohol, stress, the night shift pattern, there's some evidence, though it's weak evidence, but it does suggest that can be linked or associated with miscarriage. And there are a number of environmental factors as well that can cause that, please. Thank you. So just to give you an example in terms of age, when you look at a young lady, maybe within the age group of 16 and 20, their risk of miscarriage is about 15%. When you go through that age graph, you realize that by the time you're 36 to 40, your risk has increased by almost 30%. And from the age of 41 to 45, that also increases by 60%. The main reason is sometimes I think because of advances in technologies, also people concentrate on their career and the pressures of career development. It is normal nowadays that women may start their reproductive life story or may start to plan to have children at a later age than in the past. So we may see that maybe there is a significant rise in the number of miscarriages within women above the age of 41. It's not uncommon to see many women now getting their first pregnancy probably late in their 30s or early in their 40s. Thank you. So apart from age being a significant risk factors, we're going to look at briefly some of the causes as well of miscarriages. Basically, in most of the cases, the causes are known. We don't know the causes of miscarriages in over 50% of the cases. But for those ones that we know that 50% of those common causes is about chromosomal abnormalities. These are to do with genetic causes. So this group constitutes the majority of the miscarriages. But there are other causes like infection. There's a certain type of infection, bacterial vaginosis. Sometimes it can cause second trimester miscarriages. But any severe, infection that has, fever and high temperatures, and if you're pregnant, there's always a potential, the possibility of having a miscarriage. And there are other what we call endocrine medical conditions. So these are known as poorly controlled diabetes disease, poorly controlled thyroid disease can also lead to miscarriages. Some people have got blood clotting disorders. So when we mean by blood clotting disorder, we are talking about a condition known as antiphospholipid syndrome. We do know that it's associated with miscarriages, especially maybe second trimester miscarriages or late trimester miscarriages. Some abnormalities of the womb as well can contribute to miscarriages, even though treating those abnormalities, research has not shown that it does improve outcome in terms of pregnancy rates. And some women also can have a condition known as a weakness in the neck of the womb. So you may have heard about cervical incompetence. That's the term that a lot of the medical team usually use, but it's basically just a weakness in the neck of the womb. Thank you. So to understand how miscarriages happen, there is the clinical diagnosis of the miscarriage or clinical types of miscarriages. It's just let us go through the process, how miscarriages present, and at each level of presentation, what is actually happening. So when we talk about threatening miscarriages, we are talking about when somebody talks about a threat, it doesn't mean that that thing has happened, but it is a threat. So in the same way, threatening miscarriages, it doesn't mean that there's a confirmation that a miscarriage is happening, but it's a possibility that a miscarriage could happen. So most of the times it will present with vaginal bleeding, and the woman may not experience a lot of pain, And when the doctors examine you, they may find out that when they do an internal examination, that actually the size of the womb is still corresponding to the gestation size on how many weeks you're supposed to be. And when they look at the internal cervical os, which means the neck of the womb, is usually closed and is not open. However, if this threat continues and the bleeding becomes a little bit heavier than expected, and also with a lot of pain, then we go to the next level, what we talk about. So it's moved from threatening miscarriage. It's now gone to inevitable miscarriage. So inevitable miscarriage, it means that at this level, the miscarriage will happen. It's already started to happen. So there's no going back. So if we can go on the next slide, please. Yeah. So usually this is accompanied by heavy vaginal bleeding, and there's usually pain that follows the bleeding. And when you get examined by the doctors, you might find that probably the size of the uterus is smaller because a lot has passed out, a lot is on its way to be passed out. And when they look at the neck of the womb, it's actually, you can see that the neck of the womb is dilating and it's already started to open up. And sometimes they can see the pregnancy tissue at the neck of the womb. And when sorry, I think there's some noise in the background. Yeah. So at this point, two things can happen. it can either progress to a complete miscarriage or it can progress to incomplete miscarriage. So as we can see on the next slide, with incomplete miscarriage, you might find out that on the ultrasound, there's still some pregnancy tissue remaining inside the womb. Not everything has come out. But for complete miscarriage, this should only be made with the background that previously you had a scan before and they had shown that, yes, there was a baby inside the womb or there was a pregnancy inside the womb. And when they scan you again after the episode of bleeding and severe abdominal pain, they have noticed that actually your scan finding shows that there's nothing else inside your womb. Care has to be taken when making a diagnosis of complete miscarriage so that we don't miss out other forms of pregnancy complications such as ectopic pregnancy. So incomplete miscarriages usually also is accompanied by heavy bleeding, heavy abdominal pain, and part of the pregnancy tissue will be passed out and part of the pregnancy tissue will still be remaining in the womb. So why is this important? I just wanted to bring about, recently, there have been 3 papers that had really reviewed, systematic review. They really looked at miscarriages in detail and made recommendations on the management, diagnosis, and what services ought to be given to women undergoing miscarriages. So this is just for references. A lot of the talk that I'm talking about today and a lot of the recommendations or the management plan are based on these 3 important papers. Thank you. So, ultrasound diagnosis of miscarriages. In early pregnancy unit, as I will talk about in my upcoming slides about early pregnancy assessment units in the country, women who suffer miscarriages or women who are undergoing a miscarriage process or women who have threatening miscarriages or any early pregnancy complication, they are seen in centers known as early pregnancy assessment units. These centers are spaced out. Almost each and every hospital may have a center. There are 2 models of care. Some centers are led by nurses only, some centers are led by consultants. So you may have a consultant-led unit, you may have a nursing-led unit, a pregnancy unit. But one of the unique features in the early pregnancy unit is the use of a transvaginal ultrasound scan. This is an internal scan. It is actually the most important, essential diagnostic tool to assess early pregnancy complications. Sometimes the problem I face, because most of our people, they don't understand why they need to have an internal scan. A lot of them, they may show some resistance or they may not be willing to have an internal scan or a transvaginal ultrasound scan. Patients' wishes are to be respected at all times, but sometimes they may say no out of not having enough knowledge. Why is this crucial? Why is it important? A transvaginal ultrasound scan is actually an essential diagnostic tool. It does help us quite a lot to assess what is happening with the pregnancy and to assess and make a diagnosis of a lot of early pregnancy complications. So on the ultrasound scan, if your doctor has done the scan and they've seen a baby, but the baby is measuring more than 7 millimeters and there is no heartbeat on the baby, that can be diagnosed as a miscarriage. If the baby is less than 7 millimeters, they will ask you that they need to scan you again in 7 days. So this is not something to be worried about. It may be too early to pick up a heartbeat on the scan. Sometimes what they may see is just an empty pregnancy sac with no baby inside. And if the sac is more than 25 millimeters, then they can make the diagnosis on the scan of a miscarriage. And if the sac is less than 25 millimeters, then they need to make another follow-up scan in 7 days to see what is going on. Why do we do this? It's because we want to make sure that we are not sending pregnancies that are viable to be treated as miscarriages. So always it's important to have that window whereby the diagnosis is 100%. It's beyond any reasonable doubt that it is a miscarriage. Thank you. So we've talked already about early pregnancy assessment units. We've talked about the consultant-led units. We've talked about the nurse-led units. There are over more than 240 centers across the UK. This is your first point of contact for managing any early pregnancy complications. The referral processes differ, so it's very important that you ask your local area, your GP, what the referral criteria to be seen in the early pregnancy assessment unit. Some centers have got walk-in clinics whereby you don't have to make an appointment, you can just present yourself. Some centers, they would like referrals from your GP, so it's important that you contact your GP. Some centers also accept referrals from A&E, so if you're bleeding heavily and you're in so much pain and you can't access your GP, then it's better to go to your nearest A&E. So we're gonna talk about management of miscarriage. So management of miscarriage is really 3 principles that should govern this. One, it should be centered on a personalized care, on the needs of the woman, taking the overall clinical picture into view. And also it should take into consideration women's preferred choice of what they would want to be done. Decisions should not be made without the woman being at the center of those decisions. And 3, it's important that you are also given appropriate information. You cannot make a proper decision if you haven't been given information. So it's the duty and responsibility of the clinicians looking after you to give you the appropriate information so that you can make that decision for you. There are 3 main treatment options offered for women with miscarriages. I will go into details in each one of them, but basically it's expectant or conservative management. Sometimes you may be given a tablet to take, which is known as medical management, and sometimes you may be taken to theater to have a surgical procedure, which is known as surgical management. So first of all, we'll talk about expectant management. So expectant management. Before I talk about expectant management, there's a new evidence that has come up that really has an impact on improving the outcome of women that present with threatening miscarriages. So remember what we talked earlier on. A threatened miscarriage has not happened, it's a threat. And when you go for your scan, they may confirm that yes, you've got a pregnancy, the pregnancy is in the right place, and there's a heartbeat available. And if you are still bleeding with the baby that is okay, there are 2 things that will happen. Yeah. They will give you contact details to contact your early pregnancy assessment unit if the bleeding gets worse or if the bleeding continues beyond 14 days. However, if the bleeding stops, it's better for you to start or continue your routine antenatal care. So it's good to get in touch with your GP or your services within the local area, how you can book yourself into the antenatal care. However, for women who have had previous miscarriages in the past and they are presented with a threatening miscarriage and they've had an ultrasound scan and the baby is alive, for those women, it has been shown that giving them progesterone as a pessary into the vagina can help to sustain that pregnancy and prevent a miscarriage happening. And they can take that medication up to 16 weeks. So some of you, maybe you may go to the hospital and your doctors will be saying, you had a previous miscarriage before, you're bleeding now, your baby is okay, or we can see that it's a pregnancy inside your womb. Would like to offer you progesterone pessaries for you to take. Please don't say no. Yes, you have the right to say no, but the idea behind this is because it has shown that it improves pregnancy outcome and it can actually prevent a miscarriage from happening. So management of the rest of the other miscarriages, what we talked about, either missed miscarriage or incomplete miscarriage, expectant management. We'll concentrate on expectant management and explain what it is. Expectant management, as the word says, or conservative treatment, it's letting a natural process take care of the pregnancy. So that means you are naturally miscarrying the pregnancy without any intervention. And also, this is usually offered as a first-line management strategy, because a lot of time when a woman has a confirmed miscarriage, some of them will go into a natural miscarriage process within 14 days of having that diagnosis. However, this natural miscarriage process may not be ideal for everyone, because you may be that you are at increased risk of bleeding, maybe either because of a medical condition, or previously you've had a history of a complicated pregnancy and with a lot of bleeding, or even if there's an evidence of infection, it's better to get on top of the infection rather than to wait for the infection to get so worse before offering you to treat the miscarriage. So there are certain conditions this procedure may not be ideal. Does it work? Yes, it works. It can work to 55% to 86% for people with incomplete miscarriage, but even for missed miscarriages, it's also effective. We can work up to over 40% success rate. What is the downside of this process? It takes long. And some people complain that, I don't want 3 weeks of not knowing whether this process is completed or not. So your doctor will explain to you that the process may take longer, may take up to 3 weeks before the natural miscarriage process has happened. The next commonest treatment offered as well is medical management of miscarriage. And usually it's more effective if we use 2 drugs. One of the drugs is given initially, known as mifepristone, and this is followed up afterwards for 8 hours by a second drug, known as misoprostol. How do these work? So this medical management, these drugs, they help the uterus, they help your womb to expel the pregnancy. In that way, they help with the process of miscarriage and speeding up that natural process. They're safe and generally well tolerated, but some people may have some side effects. We'll look into the side effects and contraindications in a little bit. And it's also very successful in 85% of the cases. And also it avoids the risk of going for surgical intervention or going for surgery in 70% of the women that go through the medical management of miscarriage. It's important that your clinicians give you information on what to expect, and also on information of contraindication and side effects. A lot of the complaints I have dealt with from patients was lack of information on what to expect. So your doctors may give you these medications, you go home, you don't know what to expect, you're in severe agony, you're bleeding quite a lot. And sometimes it's also a shock when you pass the pregnancy at home, you don't know how it looks like, what you expected to do with it. So it can be very traumatic if that information is missing. So it's important that your doctors explain to you that, you may have more painful have a bleeding, crampy abdominal pains. You may pass more clots at home, but if you're bleeding every half an hour, you're soaking through and you're unwell, you need to go to your A&E, or you need to go back to your early pregnancy assessment unit. And also it's good to warn you, same with expectant management, what to expect. How does the pregnancy look like? How does the gestation sac look like, so that you're not alarmed at home when this happens. So we look at some of the contraindications of the medication. Medications may not be suitable for everyone. So as you can see on the next slides, it talks about some of the contraindications. So you won't be given a medical management of miscarriage if you've got a confirmed or suspected pregnancy outside your womb, i.e. ectopic pregnancy, or if you're allergic to any of the components of the medications that are used. If you suffer from severe asthma and which is really not controlled, if you've got bleeding tendency, or if you've got some chronic adrenal, problems. And we've talked already about hypersensitivity to any of the active ingredients of the medication. It can be used with caution in people with heart diseases or renal failure or liver failure or even malnutrition or severe anemia. Next slide, please. I will talk about some of the side effects with the medication, because this is the common question I get from most of my patients. Dr. Kalumbi, what are the side effects of these medications? So when we talk about side effects, we'll have a chat about how risks are explained to you, so that you can understand when we say something is common or very common or uncommon or rare. Main side effects of this medication is they irritate your digestive system, because misoprostol was one of the medication that was a treatment for ulcerative diseases or ulcers, gastric ulcers. So you can have things like nausea, vomiting, and things like those. So sometimes some people have got headaches, some people have got fever, some people have got, general tiredness, but these are quite rare. In women who have had previous birth through cesarean birth, they can have a risk of uterine rupture whereby the scar tissue gives way, but that is quite rare as well. Next slide, please. So let's look at the third and last treatment option. So this will be surgical management of miscarriage. Before we talk about that, it's important that your doctors may take some blood tests from you for all of the methods, whether it's conservative, whether it's medical management, or whether it's through the surgical management that we're going to talk about. The blood test is in form of a full blood count to look whether you're anemic, what is your level of your hemoglobin in your body. They may do a group and save as well in case you bleed quite a lot, that you may require blood transfusion so that your blood should be easily cross-matched. And also they're checking for your research status. If you're pregnant and you're more than 12 weeks and you are bleeding or you've had a miscarriage, then it's important that we give you what we call anti-D. Anti-D, it helps to reduce sensitization for your future pregnancy so that your antibodies within you should not attack the baby in your next pregnancy. So let's look at the last option, the surgical management of miscarriage. Basically, this is two types. One is done while you're awake and is known as manual vacuum aspiration. The other one is done while you're asleep. And this, in short, you may hear many units or many pregnancy units saying SMM. So it's basically surgical management of miscarriage. And what are the benefits of surgical management of miscarriages? Do we have to offer it to every woman? Yes, we can offer it to every woman. However, there are certain conditions that the other two options of treatment may not be appropriate. So women who are bleeding quite heavily, women who have got infection, women who have had complications in their last pregnancies, you cannot offer them medical management or expectant management. Surgical treatment would be the appropriate treatment for them. So we just want to look briefly as well on the risk of surgical treatment. Has it got associated risks? Yes, it has associated risk. And before we can talk to that, I'll briefly show you a slide on how risks are presented. Yeah. So if we can go on the slide with the risk, please. Just one below. Thank you. Yeah. So when we talk about risk, there are two things. We need to talk about how serious the harm is when it occurs and how frequent the complication can be. So many people, they find it hard from our Afro-Caribbean communities to understand how risks are presented to them. And some of them, they don't ask questions. So this is a little diagram, a table to help you to understand when we talk about risk, how common, uncommon, or rare, what does it mean? When something is very common, talk about a person in a family. When it's uncommon, it's a person in the street. When it's common, you talk about a village. Very rare things, you talk about a small town. So one person in a small town. And very rare, you're talking about one person in a large town. So this is putting perspectives into risk into place, because sometimes numbers are difficult for you to understand. But when it's explained in a way that you can relate in a family, in a street, in a village, in a small town, in a large town, it's much easier. So looking at this chart, when we look at surgical management of miscarriages, these are the complications and how rare or how common the complications are. So if we can have a look at the next slide, please. So the main complications associated with the procedure is bleeding lasting up to 2 weeks. This is common. However, heavy bleeding after that procedure is uncommon. If it happens, you have to get in touch with your early pregnancy unit or go to ANA. There are some serious risks that can happen, but they're very uncommon. Example of it is making a hole in the womb when they do the procedure. Or rare risk as well is having a significant tear on the neck of the womb when they're performing the procedure. But there are other common risks like, need to have a repeat surgery in case maybe there's still pregnancy tissue left in situ, pelvic infection, or development of what we call adhesions within your womb. Thank you, please. I'm mindful of the time, so probably I will just summarize the 3 slides all together. So the level of care that is required is, many women say the main problem is once they've had the miscarriage, they don't know what to expect when they go home. And many of them, there's no communication. Some of them, they don't understand the things that have been communicated to them. So if you have had one miscarriage, the prognostic for your future miscarriages is still quite good. So you may be given online support. So websites such as Miscarriage Association with their contact details, Credos, they look at the bereavement and support for couples that have gone through miscarriage. And your early pregnancy unit may also telephone you maybe a week to 2 weeks down the line just to check up on you and see how you are coping. If you have severe mental health problem and anxiety in your future pregnancies, you may be offered a scan, a reassurance scan around about 7 weeks. Next slide, please. So level 2 care is a nurse-led clinic for people who have had 2 early first trimester miscarriages, and you may be seen by the nurse. They may, offer to do some blood tests and blood investigation, screening you for thyroid diseases. Remember, we talked about thyroid as one of the risk factors if it's poor controlled thyroid. But Black women who are over the age of 40 and high-risk women with other medical conditions may be transferred to a level 3 care. So if we go to the level 3 care, is the consultant-led specialist clinic. This usually looks at women with recurrent miscarriages who have had so many pregnancy losses, or maybe they've had very late pregnancy loss, or they've had two fetal losses, and they will need to have full investigations to look at the causes of their miscarriages. So I'm going to leave you with this last slide saying that 1 in 5 is not just a number. Behind this number, there's a woman who's suffering. Don't suffer in silence. Let's talk about miscarriages. Let's break the barriers in our communities and seek help quite early. Don't bleed at home excessively until, at the point of losing your life for not seeking home or for suffering in silence. Thank you so much.
Thank you so much, Dr. Chim. That was a very comprehensive educational session on miscarriages. And as you said, it's commoner than we think, isn't it? A lot of people are suffering in silence, and people are not sure when to seek help. And people are terrified of even sort of seeking help because they hear all these stories. So I'm so grateful to you for such an educational session. And it's not just of benefit to the ladies alone. This is a topic that's of use to everyone, because you might have a daughter, you might have a sister, you might have a wife, so the men also need to know. So these topics are of use to every single person. It could be a friend, it could be anybody close to you, or it might even be one of us ourselves. So these are topics that we need to be well vested in and aware of. So please do post your questions in the chat box. These are being monitored and we will pick up your questions. We're now in the Q&A session. I know that sometimes some people have difficulty sort of putting their questions there or reaching out. Please, we encourage you to do that so that we can have a stimulating and beneficial discussion. So Dr. Chim, when you were talking, you mentioned the fact that progesterone can be used. The pessaries can be used for some people if they're suitable to help support the pregnancy if they are at an increased risk. Someone would like to know, are there any side effects of taking these progesterone medication in the pregnancy? Thank you.
So progesterone doesn't have an impact on the baby, because I suppose the concern is, will it affect my baby in the long term? So it doesn't have any impact on the baby. Some people can have a bit of, diarrhea. Some people can have a bit of discharge as they putting the pessaries, because you're inserting the pessaries through the vagina. So those are more like local effects, but it doesn't impact the pregnancy, and it doesn't impact on the development of the baby.
Okay. And is progesterone a good hormone for pregnancy, or is it a bad hormone for pregnancy?
So progesterone is a good hormone for pregnancy in the sense that before you can get pregnant, you have to ovulate. And when you ovulate, you have to, we usually measure the levels of progesterone to see whether you're ovulating. So pre-pregnancy, yes, it has a lot, because if you're not ovulating, then they will give you medication to induce ovulation. Okay. And once you are pregnant, there's a pregnancy hormone that is secreted by the trophoblastic cells that maintains the pregnancy before the placenta takes over. And this is known as, people you've heard in short, they call HCG. If I say the full name, probably it would be too technical for the people. That's what maintains the pregnancy a bit at the beginning before the pregnancy takes over. So in a sense, progesterone helps with the pregnancy implantation at the beginning of the pregnancy. And also is one of the markers to say whether you're ovulating and you can get pregnancy. But yes, it does support the pregnancy. It helps support the pregnancy at the beginning of the pregnancy.
Thank you. And when people are advised to use these pessaries, if that turns out to be the case in that specific case, how long can someone expect to have to use it for? Is it for the whole duration of the pregnancy, or would it just be for a few weeks? So
for the reasons for miscarriage, progesterone is also used for other reasons later on, for preterm birth and the preterm labor or threatening preterm labor, things like those. But I'll talk specifically for the use of miscarriages. They can take it up to 16 weeks. Once they pass the 16 weeks, they can stop the medication.
Okay, all right, thank you. Thank you. And also would like to know the support services that are available for people who've had a miscarriage or had recurrent miscarriages. You mentioned a few sort of support services. If we can have a bit more information on that, or maybe even have it posted in the chat box as well. That would be useful if someone wants to know. Thank you.
Yeah, so there's a Miscarriage Association. If you go on the website for Miscarriage Association, they've got a lot of information for women or couples that have undergone miscarriages. And also you've got Tommy's Center for miscarriages. That's another area whereby you can find blogs for women, information for professionals, and they've got a lot of information as well. We've got also a charity known as Credos. Credos usually help with bereavement, whereby any woman who has had a miscarriage in early pregnancy, they can contact them. On their website, they've got information as well that offer support. But also, if you're struggling, you've had a miscarriage and you're struggling, get in touch with your early pregnancy unit, because they are the ones who direct and signpost you where you need to get help. So it's important that you let them know to say, look, I've had a miscarriage, but mentally I'm struggling. And also your GP, we know that in the communities there are, mental health support facilities within the community setup. So don't suffer in silence. But the early pregnancy unit that has helped you or managed your pregnancy is the right spot to get in touch with them, because they will direct you to the right place where you need to go.
Yes, indeed. Don't suffer in silence, please. Yes. Let's get help. What sort of help can someone expect from their GP if they come to us? What sort of help should people be expecting? What is the minimum that we should be doing for our patients who've had a miscarriage?
So there are two things. For those that are bleeding and are pregnant, when you contact your GP has access for referral to early pregnancy unit. As I said, some early pregnancy unit, they see patients on the basis of a referral from the GP. So that's where your GP will be essential. We don't expect the GP to manage your pregnancy complication, but the GP will send that referral. And also it's important because the GP will judge whether you actually need to go to A&E as soon as possible, or whether he can wait and do that referral to an early pregnancy unit. So maybe the woman may not know, and she may ring the GP, I'm bleeding, I'm changing pads every half an hour, I feel dizzy, I feel unwell. The GP will give you the right information, or you can also call 111 for information as well. But it's important because they are there, they can give you advice, they can direct you, they can send you where you need to be sent.
Okay, thank you.
But after the miscarriage as well, sometimes you may have maybe vaginal discharge or infection. There are simple things that the GP can treat you. You may have, tract infection, they can treat you. So be in touch with your GP, and they will be like gatekeepers, and they will signpost you to where you need to be sent.
Yes. Okay, absolutely. And Dr. Chimwemwe, a bit of a slightly tricky question here. So when people are pregnant, does having sex increase a risk of miscarriage in the first trimester? So there's a concern for some people that, do not have sexual intercourse, you end up harming the baby, or is there any validity to this, please? Can you?
No, if they're being pregnant doesn't mean that you shouldn't have sexual intercourse. You can still have sex while you're pregnant. But if you're bleeding, then practically it's not appropriate to have sexual intercourse at that time. You need to sort out, get help, let things settle. And when everything else is normal, then you can carry on with your life.
Thank you. And when someone has had a miscarriage, how long can they expect to carry on bleeding for? I guess it probably depends on the kind or the stage of the miscarriage, but we've heard people who said, I had a miscarriage 2 months ago or 3 months ago and I'm still bleeding, and we might be concerned at some point. But generally, what is a ballpark figure of how long you might expect someone to bleed for? And beyond that, you would probably be saying you need help or you need a scan, etc.
So as I said on my table of risks, so bleeding in the first 2 weeks is very common. However, heavy bleeding, it's uncommon. So we expect women that after miscarriage, they can bleed up to 3 weeks. It's expected, it's not something abnormal. But if they're presenting with heavy bleeding with clots, that's not normal. And if that bleeding is prolonged beyond 3 weeks, it's also not normal. So those are the times that actually alarm bells should be sounding. If she's bleeding quite heavily, she needs to go back to be seen. And if she's bleeding prolonged for so many weeks, that is not right as well.
Okay. All right. At this stage, I just want to mention I've also got Charles on the line as well. He might also be joining in with the questions at some point. Dr. Chim, you're getting a lot of positive feedback, comments in the chat box. People are saying what a wonderful session has been, how very useful, how very educational. So just to let you know. Now, the next thing I'd like to ask in terms of the questions is, can any of the miscarriage treatments be safely managed at home? So someone would like to know whether it's safe to manage any of these at home.
Okay, so surgical management obviously cannot happen at home because you need the doctors, you need the anesthetists. So that's out of the question. But expectant management and medical management, yes, they can be safely managed at home. What is crucial, what is important is information. When you are told what to expect, it's not traumatic at home and you will not be surprised. So it's always good to ask your clinician, what am I supposed to expect at home? If you are having expectant management, you will have an intense, probably few hours of heavy bleeding, cramped abdominal pains. That can be expected. It's a process of miscarriage. Same with the medical management. You may have more cramped abdominal pains, nausea, vomiting, or you may pass large clots, but that is expected with the process of management. And knowing when is abnormal, when to seek help. Most of the early pregnancy assessment unit have got 24 hours contact numbers. So don't be afraid if you're at home and things are not right. Bring those contact details and they'll advise you.
Okay, thank you. So knowing what to expect is important so that when we see anything out of that, we know when to seek help. And someone has made a very important comment to say that, yes, he's an expectant dad. And he concurs with what we said, that this topic is not just relevant to ladies or women, it's equally important to men as well. And he's really been sort of equipped with the information. So he's really grateful. Dr. Chim, is there, I'm just scrolling through my questions now. Are there any specific risk factors in Black women or any genetic predispositions that may cause Black women to be at a higher risk? Also, do things like, night shifts, being stressed and all those things, can these things contribute to miscarriages at all?
I think this stress is not a good thing for any medical condition, And obviously, there were some papers that came out that looked at night shift pattern. And yes, it does have some contributory factors to miscarriages. But however, the evidence from those papers were a little bit weak, but it's something that is there. So if you have a very stressful shift pattern and you're pregnant and you started maybe bleeding, it's better to speak with your line managers, review your situation, reduce the amount of stress, and see how things go. I think Black minority or people with Black ethnicity, women, you realize that their pregnancy outcome is poor compared to Caucasian women. And there are many factors that factor into that. It's not only the miscarriage aspect, but if you look at the pregnancy outcome, I'm sure you know about, Black women are 5 times more likely to die from giving birth than their counterpart. Yeah. So some of the things are to do with accessing help or medical facilities. Some of the things are, to do with genetic makeup, genetic predisposition. And it's not an easy thing to say, yeah, this is because of that. We are still conducting more research, we still want to know and understand why. There are also some, inequalities in the systems as well. So it's a multifactorial issue which needs to be looked at different angles. But yes, it has been shown that Black women are also more likely to have a risk of miscarriage.
Okay. Do we see a similar trend in the Black African and Caribbean countries? So I'm not talking of the Black African Caribbean population here. I'm talking of in those countries. Are we seeing a similar trend where, because obviously that is where the majority of these people are we seeing the same trend in, our people back home, to put it just literally?
So there are two things there. Our people back home in our especially, maybe let me talk about sub-Saharan Africa and the
Caribbean
rural communities. There isn't data. People suffer in the villages. You won't even know. It's even a taboo to talk about miscarriage. So the figures and the statistics may not be appropriate because there's a lot. Not all the miscarriages reach the hospitals. The majority that you see are the ones that have tried to do probably street abortion. So you see the end bit of the complications of those processes. But the numbers of people that suffer from miscarriages, a lot of them, they just stay in the communities, in the villages, and you wouldn't know about them. So there's data that there's a gap in the data analysis. But for countries like in the Western countries where data is available, when they analyze that data, that's the factor that is coming up.
Yeah. Okay. So really the reporting is not the same, is it? A lot of things don't get back home. So the numbers could be a lot more than are being captured.
Yes.
Yes. And what is a blighted ovum, please? And is this a genetic thing? Is this a sort of a non-genetic predisposition to having a blighted ovum? What exactly is it? We hear of it a lot.
So when I said 1 in 5, it's not just a number. There's a woman behind it. There's a couple that are grieving behind it. It's the same with terminology. A lot of our terminology as medical doctors can demean the miscarriage. So in the old days, we used to say blighted ovum. But actually, it's not a blighted ovum. Yes, that's the explanation. But it's a miscarriage that has failed to grow. It's a pregnancy that has failed to grow. So what you have, like I said, you have an empty gestation sac. So we talk about gestation rather than blighted ovum, but basically a blighted ovum was an old definition of an empty gestation sac. So you have a gestation sac that had started, but that pregnancy is not growing appropriately. Therefore, nothing has developed within that gestation sac. There's no yolk sac, there's no baby, it's just an empty gestation sac.
Okay, now in terms of the sperm, so someone is asking a question, I'm just scrolling to the right question. So can we hear about sperm quality and whether this influences miscarriages at all? Is there any link between quality of sperm and increased risk of miscarriage? Thank you.
So when we talk about age as a factor, the same way why women above the age of 40 and men above the age of 40 or 41 as well are at increased risk of miscarriages is to do with the quality of the egg and the quality of the sperm. So those are the factors that contribute to miscarriages. There's also another area which is more detailed, is to do with what they call sperm fragmentation, but I don't want to go into it. It's a little bit more detailed and complicated, but the bottom line is age does impact on the quality of the sperm one produces and also on the quality of the egg one produces. So as we can see, that age is one of the factors why because of the chromosomal abnormalities that arise from such pregnancies.
And would age be a factor only for a lady who's having her first pregnancy, or is it a factor regardless? So for instance, if you compare a nullip, someone who's never had a child and having their first baby after the age of 40, and compare someone who say had 6 children already and they're having their 7th child after 40, are the risks comparable at all? Does it matter if you've had children before or not?
Age is a factor regardless whether you had previous pregnancies or you've never had a pregnancy. However, a history of a previous successful pregnancies in a woman who is having recurrent miscarriages, that can make a difference. One has got a better prognosis if you've had previous normal birth before than one who has never given birth before. So that's where the difference comes. But age is a factor regardless whether you've had previous pregnancy. You see women who have given birth but as they're encroaching maybe over 40, then they start miscarrying. So we know that probably age is what is contributing.
Okay, right. So it's an independent risk factor anyway in these circumstances. Yeah. Okay, Dr. Chim, thank you. Lots of questions and lots of comments about how useful it is. So again, I just want to keep feeding those back to you so that you know the useful session. Maybe a little project for you, which might be useful. Someone is saying, are there any resources with information about what is normal and what is not normal so that people know what to expect? I'm sure there are probably leaflets, but are you able to send any information to us so that people can contact health@CAHN.org.uk or even signpost to the website? These can probably be put in the chat box as well.
Yeah, sure. I'm happy to do that. So Miscarriage Association, I can send you their link. They have all the information. Thomas Center for Miscarriages as well have got lots of information. And these are credible resources that we use. If you ask Mr. Google will bring so many things out there which are not appropriate. But this Miscarriage Association, Thomas Center for Miscarriages, Credo, Sons, they do with a lot of bereavement and stillbirth, but they also have important information that one can look. There's the Ectopic Pregnancy Association as well. So I will send you a list of where they can find this information. The Royal College of Obstetricians and Gynecologists as well have got really good patient leaflets that people can access to. So I will send them to CAHN, and CAHN, you can share them to the people.
Okay, all right. So do stay till the end, please, everybody, because maybe at some point, if Dr. Chim has 2 minutes, she might be able to type a few things in the box as well. But absolutely, please do get in touch with health@CAHN.org.uk for further information. So there used to be a policy that someone has to have at least 3 miscarriages before an investigation is triggered, into could this be recurrent miscarriages? Is that still the case, or has this policy changed? And do spicy foods have any impact on miscarriages at all, or any particular foods or cosmetics or perfumes, anything along those lines? Thank you. Two for one.
Okay. So we'll talk about environmental factors. So environmental factors, there are things like, smoking, pollution, and all sorts of things. There is some evidence there that, yes, it can be associated with miscarriages, but the evidence is weak. It's not very strong evidence. Food, I would say, eat healthy diet. If you eat things in excess or in severe amounts, they always have a side effect to it. If you eat very hot, very spicy food and your digestion is not good, sooner or later you'll be complaining of indigestion. So everything else should be taken in moderation. But I have not come across any papers, and we learn every day, and I'm open to learning, that says spicy food causes miscarriages. So that I'm not aware of. But what I know is everything else that we do, we should do it in moderation. The other aspect Sorry, let me just close this. The other question that they've asked, so I've not touched about recurrent miscarriages because that's a broader topic on its own. So the definition of miscarriages, recurrent miscarriages, still is the same that the Royal College of Obstetricians states, which is 3 or more pregnancy losses. However, there's nothing preventing investigations to be offered when a woman has had 2 pregnancy losses. Yeah. That's what in my last 3 slides, we talked about the graded level of care. So if you have 1 miscarriage, what should you expect? Expect signposting where you can find information. Why? Because it's most likely a sporadic miscarriage and your chances of normal pregnancies in future are quite high. If you've got 2 miscarriages, then you can be offered to be seen in a nest-led clinic. So they will take your history, they will do some of the investigations. And also, even if you've had 1 miscarriage, say you've had a miscarriage at 23 weeks, you will be fully investigated because these are things to do with the placenta. So we need to see, have you got clotting disorders? Have you got other things that are going on? So traditionally, yes, we used to refer women to recurrent miscarriage clinic and to start investigations when they've had 3 or more miscarriages. At the moment, it's more like levels of graded of care, 1 miscarriage, information, signposting, 2 miscarriages, nest-led clinic, and offer some investigation. 3 miscarriages or more, or even 1 late miscarriage, then you need to be seen in the specialist miscarriage clinic. But the definition has not officially changed. I know ISHRA, some of you, is the European Society of Human Reproductive Health Medicine. They use the definition of recurrent miscarriage as having 2 or more pregnancy losses. But the RCOG at the moment, we're still using 3 or more miscarriages until maybe an update comes up, but that's what is available.
Right, okay. So if someone finds themselves in a county or an area or under a CCG where they have had, say, 2 miscarriages and they're seeking help or wanting a referral, and it gets bounced back to say, oh, no, you haven't had 3, so you don't meet the criteria. What are their options? What does this lady have as an option?
So the GP can do some primary care investigations. As I said, check the thyroid diseases. If they had 2 miscarriages and these were fetal losses, by fetal losses, I mean she's had a scan, they've done the scan, there's a heartbeat, and the person was maybe 9 weeks or 10 weeks or more. The GP can look at clotting disorders, especially antiphospholipid syndrome, because that's one of the commonest cause of late fetal losses. So there are things that can be done at the primary level, but you're right, the referral to a specialist clinic, it's patient-centered depending on the history. Same way, some women have had biochemical pregnancy losses. I've not touched those ones. So i.e. they do a pregnancy test at 4 weeks, is positive, 2 days after they start bleeding. It's very difficult psychologically to tell that woman that you've had a biochemical pregnancy, because to the woman, that's a pregnancy loss. And sometimes it's better to say you've had an early pregnancy loss. So those pregnancies, and it's very difficult, no amount of investigations will be found a reason why that has happened, because we know biochemical pregnancies are quite common. But definitely confirmed pregnancy losses on scan or history suggestive of late pregnancy losses, those should be investigated.
Okay. Dr. Chimwemwe, I think you've got a lot of unfinished business. We might need to bring you back to talk about a few more. So please let us fill the feedback forms that are being sent around or will be sent around. The polls, let's complete those, because we do appreciate your feedback and we need to know how to improve these sessions that we bring to you. So some of the comments, Marg has made a comment to say the risk is 43%, so almost twice more likely, which is shocking. I think she's referring to the increased risk in Afro-Caribbean women.
Yes.
Some also made a comment, 5 times more is real and multifactorial. Apart from inequalities and intersectionality, our health-seeking behavior also plays a part. our socio-cultural origins influence how we seek healthcare, even when we are abroad. Yeah, that's very true, Loretta. Powerful comment. Lots of thanks as well to Dr. Chim for highlighting important information and for educating us. Now, someone has also asked, does abortion increase the risk of miscarriage? So before you answer that question, Dr. Chim, can you first of all tell us the difference between abortion and miscarriage? And then, does abortion increase the risk of miscarriage? Thank you.
Okay. So when we talk about, I know that there are still some areas that talk about miscarriages as abortion. So threatened abortion, incomplete abortion. Abortion was the terminology we used to use before in the past in the context of miscarriages. Because when you talk about abortion, it's actually terminating the fetus or terminating the pregnancy. It's different from miscarriage. Miscarriage is spontaneous, okay? So if in terms of early pregnancy unit assessment, the appropriate language and terminology to use to women who are having spontaneous, what you would call abortion. Abortion is just a terminology, which means ending the pregnancy or expulsion of pregnancy tissue. So that's what abortion means. But appropriate terminologies to use, we changed it quite some time ago. We use the terminology of miscarriage to signify probably to spontaneous miscarriage as opposed to abortion. So when you talk about abortion, there are also abortion services in the UK, and abortion is a topic on its own. It's actually talking about terminating the pregnancy. So doing something to terminate the pregnancy as opposed to having a natural process that the pregnancy is being terminated. I don't know whether that makes it clear. So abortions don't cause miscarriages. So it doesn't mean that when women have gone for abortions in future pregnancies, they will have miscarriages. No, abortion doesn't cause miscarriages. But I think it's unfair and unkind for a woman who is going through a process that not according to her will, that pregnancy is coming out, to say abortion. So that's why we use the terminology miscarriage.
So the two are not quite the same. One is actually someone taking a step to terminate, and the other one is happening out of their control.
Yeah. And then also sometimes people can have termination of the pregnancy because of medical conditions. So even within the context of termination, pregnancies or abortion, there are those that are done because of medically indicated terminations, and those that are done because the woman has chosen to do that. So there are also categories. But in the context of the miscarriages that we're talking about, I think it's appropriate to use the terminology miscarriage than abortion.
Okay, thank you. Okay, a few more questions for you. Sorry, we're squeezing every bit of juice out of you.
No problem.
So I've been told I have a bulky uterus. What is it, and does it contribute to a risk of miscarriage? And then the second question is, if a woman is having recurrent miscarriages when they are being tested, would they have a sperm quality testing? So I guess they mean, would the partner have a sort of sperm analysis done? Thank you.
Okay. So to talk about a bulky uterus can mean anything. Is it bulky because she has fibroids? Is it bulky because she has a condition known as adenomyosis? So when you're given a report from your doctor or from your gynecologist which says you've got a bulky uterus, ask, what does that mean? What have they found? Because you may have adenomyosis, which is a different condition that can cause a bulky uterus, usually presents with painful, heavy periods, and some people may struggle with that. Or you may have that you've got multiple fibroids within the muscles of your womb. So it's important to do that. In terms of the sperm testing, there are two things here. If the problem is about infertility, so failure to conceive, you've been trying for a while and you can't get pregnant, then it's essential to do the sperm analysis on your partner, as well as they are doing investigations on you. But in terms of miscarriages, doing sperm DNA fragmentation is just for explanation purposes. It doesn't really have a treatable outcome that you can treat it. And that's why it isn't done under the NHS. Privately, yes, you can have that procedure done for your own information, but does it have an impact on your risk or rate of miscarriages? Probably not. So it's not routinely offered because we are still looking into it and to understand, and more studies are being done, and there are a lot of topics, and there are experts in, IVF, people that look at that aspect of sperm problems. But you won't necessarily have sperm analysis just because you're having miscarriages.
Okay, thank you. So some of the comments: excellent presentation. Thank you, Dr. Chim. Thank you for highlighting the poor data collection in African countries, which makes it difficult to compare outcomes for women in the diaspora. Someone is also saying, many thanks, Dr. Chim. Excellent and insightful presentation. Very informative session. Thanks for empowering us. Corinne's made a comment about terminology. She said, wealthy women are more likely to claim to have a miscarriage when they have actually had an abortion. Figures become slightly different. So I guess she's sort of referring to how the two are wrongly used interchangeably. Dr. First, I think you have your hand up. Please post your question in the box for me, and I'll pick it up. Thank you for your regular contributions to the session. And also a lot more, comments about the fact that it's been a very useful session. I'll just hand over to Charles in case I've missed out any questions, while we either let Dr. Ambrose post his question or allow him to unmute and ask his question. Charles, are you there?
Yeah, I'm here. No, I don't think you've missed any question. We can bring in Dr. Ambrose for him to ask his question. And I've learned an awful lot. And certainly this is not just for women, but, for men, because we have sisters, cousins and nieces as well. So back to you, Dr. Ambrose.
Sorry to try to ask this question. I have enjoyed this topic a lot. What it is that I've been following the events going on in the US regarding all these pro-life and abortion laws. And I did listen to one of the pro-life ladies say that if a woman has had recurrent abortions, that's deliberate termination of pregnancies, that it can affect subsequent conception and lead to miscarriages in future. And I know some people hold that myth. Is there any evidence in this regard? Thank you.
Thank you, Dr. Ambrose.
Thank you so much. As I say, there isn't any strong evidence to say that if a woman has had repeated abortions, it can cause miscarriages. However, there are factors that we need to look into it because it's like a blank statement. So remember when I talked about surgical management of miscarriages and the complications, one of the complications is adhesions. So the more surgical treatment you may have, the number of surgical treatment you may have, the higher the risk of adhesions. So when they've had repeated abortions, how were those abortions done? Were these street abortions? Were there infection involved? Because if there were infection and infective processes, you can also affect your tubes. So in future, you may struggle to get pregnant if your tubes are blocked. And if there were adhesions within the lining of your womb, then that as well sometimes can affect your future pregnancies. So I think it should be looked at individualized history because yes, people may have repeated abortions, but how those abortions are done is different, and how each individual has complications is also different. But there aren't many papers out there that says the more abortions you have, the higher your risk of miscarriage.
Thank you. Thank you. So I agree with you on the surgical components as well, Dr. Chim, because I guess with any procedure, there's that risk of possible damage. And maybe, as you've said, if there are adhesions or damage to the lining of the womb in that process, it may increase the risk. But medicine is an evidence-based science, isn't it? So as long as there isn't any evidence gathered and we don't have the data, it cannot be stated as fact. But maybe that's an area worth looking into as well. Probably something worth exploring. The Bring Back Dr. Chim campaign is growing stronger and stronger. So I'm having messages backdoor saying we need to get Dr. Chim back. So please, when I contact you, this is just not me. It's everybody saying we need you back. This one is very busy. So we'll try our best. But I think it's been really useful and very insightful, very, very, very educational. And we've had lots of positive comments and positive feedback. Please, our valued viewers and audience on all our social media platforms, we really appreciate your time. Can we please complete the feedback forms? We really need to know what you think about these sessions and how we can improve these sessions, make them better. Now, someone has also said we also need research on Black women, miscarriage, and also our risk of fibroids as well. So I don't know whether that is something which Dr. Chim, you can say something a little bit about people having fibroids and their risk of miscarriage. Otherwise, I'll let you say your last few words and we will do the closing bit.
Yeah, so in my table of some of the causes of miscarriages, we said about uterine abnormalities. When we have a chance to talk about recurrent miscarriages, and I'll go a little bit deeper on about uterine abnormalities and what to find. So there's a section there about polyps and fibroids that yes, they can contribute to miscarriages depending on the location of where they are within the womb. If they are within the lining of the womb, yes, it can be a contributing factor to miscarriages. It's true, Black Africans have got maybe higher risk of fibroids or prone to fibroids than Caucasian women. In terms of research, yes, there are a number of research that look into epidemiology statistics of miscarriages, and that includes as well the Black African communities and other ethnic minority communities as well. So it's an area that is heavily investigated, looking at the causes of miscarriages. They do break down into epidemiological statistics to have a better understanding. So that's what I can say to that question. Yeah, but it's been a privilege. And once again, thank you so much, Diana. Thank you for the executive of CAHN for inviting me to be on your platform. I really appreciate it. And thank you for our audience as well.
Thank you so much. CATHIP Health Hour is privileged to have you, and we're really grateful for your time, for a very, very educational session today, insightful, and simple to understand. You really broke it down and you really made it relatable as well, so that we've all benefited one way or sorry,
can I just say one thing which I really I think is crucial? I forgot to mention about this. As I stated earlier on, my views are from my professional expertise, but also as a Christian, as a child of God. Where medicine has failed, going through miscarriage is a painful process. And me as a doctor, where medicine has no answers and where medicine has failed, as Christians, we should always have our hope. There's always hope. I think I look at it as Christianity complements the hand of God. So there's always an answer, and people should not live without hope. Especially many of our African communities, they go into depression, they lose hope in life. But as a child of God and as a Christian, you should not lose hope. There's always hope. So that's what I wanted to conclude on as well. Thank you.
Positive note as well, that we should never lose hope in whatever situation we find ourselves, and seek help and keep going. So we will have more sessions on women's health, reproductive health, and we will do our best to bring Dr. Chim back. If you can quickly, while we do the closing, post in the chat box whether the Saturdays is fine for us or whether people would want us to have sort of a midweek session, just randomly post in the chat box. That will be useful. Remember to also fill in the feedback forms, and remember to join our CATHIP Health Hour sessions week in, week out on a Saturday morning, and also our Healthy Heart sessions on a Tuesday. I say thank you to all the team and to everyone who works tirelessly behind the scenes to make this possible, and to all our partners. It's been my privilege as well to host you today, and I hand over to Percy to do the closing for today. Thank you once again, Dr. Chim. We've really enjoyed this session. Thank you.
All right. Thank you so much, Dr. Diana. A very familiar face in the house. Really appreciative of your efforts week in, week out in hosting the section. I mean, it's been brilliant. Good to have you as always. Then just to say massive thank you to Dr. Chim. I mean, very insightful presentation. I personally have learned a lot, and there is a lot to take away from it as a Black man, really. And in terms of the family I represent and people around me as well. So very much useful. Just to encourage us, as always, to tune into our next session as well. So next Saturday, we've got another interesting topic. It will be focused on osteoporosis and osteoarthritis. So do endeavor to tune into that. I mean, it's just increasing our knowledge as well. We know how some of all these things affects our community, really. And in the build up to that, we've got Healthy Hearts. That will be on Tuesday evening. We'll have a really sound dietitian on the call. And as usual, our hosts will still remain Dr. Iba and Orlando to take us through the physical activity at the end of it, really. So just to say massive thank you to everyone. Do look out for these sessions that will be upcoming. And as always, we've got our services freely available to everyone. Do reach out, and we're always there to help and to support. You can contact us. Our helpline numbers are on there. In the chat box, I'm sure my colleagues are posting them. The details are out there as well for us. Anything you want, if you want any help, is it counseling, is it advocacy, just reach out to us at help@CAHN.org.uk. And also just to say massive thank you to our partners as well, who will drive this program with us week in, week out, the Enfit Caribbean Association, the Royal Assembly, Redeemed Christian Church of God. We've got Rafa International Development Agency, Croydon BME, and of course the Black Health Initiative. Just say massive thank you to them, and also their contact details are there. You could also engage with them. They're also championing great works around not just health inequalities really, but also the wider social determinants of health. So massive thank you to everyone on the call. Thanks for tuning in. We encourage you to come along with us next week again, and please make sure you bring someone else to the program. Do continue screening it in your homes, have it live playing, and lots of knowledge to take, really. So just to say massive thank you. And as we're exploring other days that we could possibly have the program as well, please do interact with our feedback forms. Do get in contact with us if you have anything that you feel that could help in terms of developing the program. I mean, it's our program, it's helping everyone, really, just not just the team, but the whole community as a whole. So just a massive thank you to everyone, and bye for now. Thank you.
Bye.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@CAHN.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.